Okay, we're back. We have Sarah Lord Ferguson. And one, thank you for coming on, Sarah. Two, could you just provide a brief intro and background on yourself before we rock and roll?
Yeah, definitely. Thanks, Chris. It's great to be here. This is my second time being on a podcast, so bear with me, and thanks for the warm welcome as well. I am a clinician researcher. I've been in physiotherapy for about 10 years now. And I have a little bit of a unique background because what I study is actually more from the business and psychology perspective. So my PhD is actually in business and marketing, but my field of study is services and specifically healthcare services and specifically within that physiotherapy. And I look at patient expectations when they come to a physiotherapy clinic.
How did you decide to go down that specific niche area?
Yeah, I guess I should also say that I was born and raised in Vancouver, British Columbia, Canada, and I've lived here all of my life and went straight from. I've been in school for pretty much my entire life, and I went straight through to university from high school. I studied kinesiology, and then I went straight into a master's program for physio, which is what the kind of minimum requirement to be a physio here is in Canada. It's a MPT or Masters of Physical Therapy. And I thought immediately I wanted to be a business owner. I wanted to open my own clinic. And my mom, I saw her be a businesswoman. She was a dentist, and I just wanted to do that the whole time. So I got in, got my hands dirty, started working clinically full time, and I immediately was like, I need business skills. So what do? I did my master's in business, my MBA. And little did I know that during that experience, I would be shoulder tapped to do my PhD. So I never planned it at all. But I guess after enough whining and dining, I said yes to do the PhD, among other great opportunities and factors in my life that allowed me to move into the research realm. And I said, if I'm going to do this, it has to be on physiotherapy. And my life took a bit of a little detour. And so I have not opened my own physio clinic yet. And I don't know if I will because there's a lot of value to provide in what I do now. But yeah, I'm very passionate about physiotherapy and the rehab industry and about business. And this was my opportunity to kind of put them together for the greater good.
Yeah, so you currently right now you're just doing research. Not just, but you're solely doing research.
Actually, Chris, I wear so many different hats. So I'm a full-time researcher. I'm actually just at the end of my PhD, so I'm almost done. And I also teach. I actually teach marketing and services. And I also work as a clinician 2 days a week at a private practice orthopedics clinic, which is the same clinic that I've been in since I graduated. So I keep my foot in that door. I don't want to lose my clinical skills, and it directly informs my research, and it is my research setting. So it's pretty much where I get all my participants, not just from that one clinic, but because I'm involved with my profession. And lastly, I'm also on the board of my professional association here, the Physiotherapy Association of British Columbia, or PABC, and that keeps me really informed and in the loop and with our members. And yeah, so lots of different things that feed into my research and articles for sure.
Well, that's great with all these perspectives because in this paper we're going to discuss, it talks about a lot of different avenues and multi-stakeholder, multi-level, and you're seeing it from a lot of perspectives in education, research, clinical practice, marketing. So the primary thing we're going to discuss today is one of your recent papers. I think it was published in Musculoskeletal Science and Practice called "Should we give patients what they want? Patient expectations and financial pressures need to be addressed to increase uptake of evidence-based practice." So I thought it was a fascinating short read, and you were the only author. You wrote it yourself. You kind of alluded to it initially, but can you discuss why you decided to write this kind of commentary and viewpoint?
Yeah, definitely. So basically, yeah, it comes from my experience, right? Uh, I was number one frustrated by research articles that I'm reading. And I'm in that space where I'm reading these articles and it's just like, basically villainizing physios for not following evidence-based practice. And it's also the same thing in social media. It's just kind of this like big kind of argument between physiotherapists. And it was super frustrating to see that in a public facing forum, like, when our association would post something, it would cause all this, physios would be just arguing at each other. And I'm like, why are we arguing at each other? This is a public facing forum where we should be in support of each other and in our profession so that the public doesn't think that we're just, all over the place and we have kind of bad rapport within our profession. So that was one thing. Social media and research both saying, you know, just do it, just follow the evidence, it's so easy, why aren't you doing it, and kind of villainizing. And then my own experience being a researcher, I'm very pro evidence. I love like learning the newest kind of thing, and also seeing that things are being supported over time, and also being aware of the research and aware of all the clinical guidelines and all the great knowledge translation work that's happening. And so if anybody should be able to be evidence-based, it should be me. But I'm in my clinical practice being like, struggling to do this, like really struggling to do this. And, you know, it's hard. It's hard to implement the evidence, even if you are aware of the evidence and you agree with the evidence. And so I just wanted to give that perspective in saying that, well, clinicians don't operate in a vacuum. I know that I'm not the only person that is struggling with this because I talk about it in my research with my research participants and with my colleagues and at conferences. And, it's hard to, in private practice, which is my research setting, where you need to make a living, and the only way that you can make a living is to see patients. It's hard because you have to manage those expectations, and you have to be able to balance making a living and following the evidence, right? And that's hard. So I just wanted to bring that to light.
Do you, with your research, have you noticed similar difficulties in other healthcare professions or discussed this with other individuals outside of physio?
Oh, well, not in my research specifically, but definitely in discussions for sure. I think that it is a general trend when a profession starts to gain more knowledge behind it. There's a tension between trying to do what you've always done and try something new or shift. And I think it's kind of our profession, because it's a little bit newer, is at this maybe inflection point. And we've accumulated a lot of research now, but the societal shift or the kind of socio-cultural dynamic that needs to shift takes a lot longer. It takes time, right?
The discussion on evidence-based practice and implementation and the realities of it, can we start with defining what even is evidence-based practice, if you have a good working definition for it?
Yeah, I was thinking about this. So it's definitely this buzzword, as you say. And I actually participated in a study a while ago, and I can't remember right now if it was evidence-based or patient-centered care, which is another one of those buzzwords where it's like, what does this actually mean? And in writing this article, I actually I had some pushback from reviewers around that, and I tried to actually change to be more focused on following the guidelines, like the clinical guidelines, because that's a lot. It's more concrete. It's something you can actually measure. It's like, do they follow the guidelines or not, as opposed to this, elusive concept of, evidence-based practice. And I mean, I don't have the answer. If you Google it, if you read like academic articles, there's all sorts of different definitions. But I guess a generally accepted one is that you as a clinician are informed and you provide that information to your patients, and then actually the patient has the opportunity to input and to decide, right? It's not just this kind of top down process, which is sometimes the way it's portrayed, is this like the clinician is this all-knowing thing, and they have the evidence and then they just need to impose it on the patient. And that's not what I'm trying to say at all. The patient does need to be involved in that decision making process as well, and if they decide not to follow the evidence, that doesn't mean that you did a poor job as a clinician. Because if you present them with all the information, they have the choice to they have to make the choice. It's informed consent, right? So it's important to kind of bring in the patient perspective as well, right?
And if you're utilizing or discussing EBP as primarily around guideline recommendations,
Mm-hmm.
what about areas of research where there aren't enough information or there's not any guidelines to utilize when guiding care or having discussions with patients?
Yeah, it's hard because as like a newer profession and a newer kind of research profession, there are definitely, and just in general in our space, there's so many new things always coming up and technologies. I think we have to come back to principles. I used to teach first aid, and it was all about principles. And I used to have patients, or sorry, not patients, students saying, well, what about this situation? What about this situation? What about this situation? And it's like, okay, again, it's coming back to the principles. And so I guess the principles would be, what do we know about this? What can I share with my patient? And how can I act in a way, how can I use my own clinical reasoning to act in a way that is within my scope and within what the college would deem appropriate? And sometimes there's a gray area there. One of the things I had down to talk about here is just that we're kind of maybe lucky as physios in the sense that what we do just can't really kill somebody or cause significant amount of harm. It's not like we're heart surgeons or brain surgeons. Of course, there's probably a lot of debate on that. And that's also probably why we're having these conversations, is because what we do is not as black and it's gray, right? And so, if you as a clinician do something that's against the guidelines without telling the patient and you kind of force it on them, then, but it doesn't actually hurt them physically, but are you causing psychological harm by telling them that it's going to fix them or by creating a passive reliance? So there's a lot of nuance there, right?
Yeah, and to your point, if it's not a life or death and there's no immediate feedback mechanism besides you provide potentially an intervention and it may feel good, that may be the only initial response, that to you
Mm-hmm.
means that this intervention is beneficial or efficacious, when in fact there's a lot of reasons why something may or may not work. And then you have kind of this self-fulfilling prophecy of continuing to do it and having these short-term improvements in symptom modification, and you negate what the bigger picture is and
Mm-hmm.
what these other contextual factors are that may be leading to some of those kind of changes in sensation and like happiness from a patient. So
Yeah.
from there, the first portion of the article is the messy realities of EBP, and we were already kind of discussing it. But do you want to dive into more of what is the messy reality? What are some of the things that makes it really hard to implement these guidelines and have these discussions with patients?
Yeah. So in kind of doing my research for this article and looking at what's been written so far, it's funny because it's like you think that everybody initially thinks it's an awareness issue. It's like, oh, well, the clinician just doesn't know, like it's ignorance, right? But actually accounts for a small amount of people, right? Like most people are pretty pretty aware of what the guidelines are or have general ideas about them as we see trends change in our industry. And also, most people are most physios are pretty pro evidence. They think evidence is great, and they think the guidelines are great, and it's not for like lack of wanting to follow these things. And so when you take a step back and you think about why in practicality it's not happening, you have to realize that there's a lot of these contextual or environmental factors that come into play. And the individual clinician, when they're in the room, at least myself, I really care about my patients and I want them to get better. And, I'm sure you've had the same experience. You just want to bend over backwards to make their life better. And it's so frustrating when you can't change their mind about something, right? And that's kind of really what it comes down to, is having the skills to be able to assess patient beliefs, understand where they're at and what they expect, and then managing those expectations. And unfortunately, we don't get really, at least in my experience, like don't get taught those skills in school, or maybe you might get taught some baseline kind of behavior change, but you don't really know how to implement it. You don't know the right questions to ask. And so I think it's very hard for new clinicians. They come out and they're like, rah, 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 I'm going to follow these guidelines and evidence. And then they get into the nitty gritty and they see a patient across from them that has been going to physio for 30 years and has these deeply entrenched belief systems about physio and about the healthcare system and about what clinicians do. And they're like, they just, it's a dumpster fire. Like, I mean, that was a really long-winded way of saying that, one of the factors is just like not having the skills to kind of guide that. But the other things that really were the kind of the intro of my article and were the financial pressures and well, the patient expectations was the thing I just talked about. But for financial pressures, again, we're looking at the environment. It's never been harder. It's never been harder to make a living, especially where I live in Vancouver, but everywhere, right? You're dealing with clinicians that they have to pay rent, they have to care for their family, and a 1-bedroom here is $3,500, and I have a mortgage like over $5,000, so it's pretty it's pretty hard to make ends meet. And the only way that you get paid is if your patients come back. And you don't, like, a lot of I'm not sure how it works in the US, but in private practice in Canada, you have most people are contractors, and so you get a percentage of a patient visit, so you only make money if you see a patient. So it's never been harder to make a living, and there's more competition. There's everybody's selling pain relief. We're not just competing with other physios, and there's a lot of competition amongst physios now, but we're also competing with every other kind of provider as well. And we're also competing with products as well. So everybody's selling pain relief. We're just another provider, right? And the last thing I'll say is just that this within the context of this increased commercialization of physiotherapy, we have an increase in the impact of social media, and customers or our patients have more power. They can very much damage our reputation with an online review, and that never really used to be the case because it just didn't exist on the extreme that it does now. And so as a clinician, if you don't manage those patient expectations properly and someone leaves unhappy, they can damage your clinic and your credibility as a clinician as well. And that's just a scary environment to be living in. I mean, I am by no means saying, just do whatever the patient wants, but I wanted to write the article to talk about these factors and to have these discussions.
Yeah, it's really the ethical conundrum, and that's I don't even know how I found this paper, but I just liked the title and it made me read it. But like, should we actually give patients what they want? Where a lot of the common, I don't know if it's an excuse, but things people say is like, if I don't give them what they want, and you mentioned this in the paper, they're going to go see another provider that will do that, and I can kind of envelop the rest of my care with more evidence-based things if I give them a little bit of what they want. And I, I'm in a very lucky setting where I'm salaried and there's not this pressure to where if I have an open caseload one day, I'm not going to lose money. But I know for a lot of people, if they own their own practice or they're in a setting where it truly depends each day, if they have a full caseload, how much they can make, that there's a lot more pressure. But I don't know if that's a good idea to just kind of, I don't know. I compare it to like if we were in a other medical context, would a PCP give a patient what they wanted just because they asked for it? What do you think of outside of financial pressures to maintain and keep patients in the clinic? What is the downside of giving patients something that they want that's not evidence-based?
So when you say PCP, is that just like a general?
Like a general physician, a primary
Oh, like a GP
family
general.
physician.
Yeah, got it. Okay. Yeah, yeah. Oh, I think this is 100% happening in all the professions. It's like patients are very demanding. And I I mean, if you look at guidelines for giving out imaging, I mean, we've seen imaging go crazy, right? Like, why is that happening? I mean, it's obviously multifactorial, but one of them is patients are demanding it. And, I think that that's also kind of like the opioid crisis as well. I mean, obviously, again, another complex, multifactorial type of situation. But at least with the healthcare system the way it is, with short visits, like in Canada, it's like you have 8 minutes when you have a doctor's appointment. And so, I think there is a lot of that going on. I don't think that anybody's doing it on purpose. I think it's important to say that. It's not like I'm like, clinicians are like, I'm just going to do this because they want it. I don't think it's that, like, I don't think we can reduce it to that. I think it's actually happening in this grand, like, even like subconsciously, that there's just so much going on. There's time pressure, and this is just kind of the end result. And it's not an excuse. I don't think that the saying, there's increased competition, it's hard to make a living. I'm not saying that as an excuse. I'm saying that as it's part of the picture. And I don't think it's driving most clinicians' behavior unless you're just like seeing dollar signs and you're only caring about, how much money you make. I think the vast majority of clinicians, myself included, is trying their hardest to do the best they can for their patients because they really care in the environment that we live in.
In the clinic you've been at since you graduated, have you had situations where you've provided the evidence and what the kind of options are and understanding where they ultimately have the final decision of whether or not they want to receive care of what you're outlining? Has there been negative responses, or is this,
There has 100%. Yeah, I actually had one patient like walk out the door one time, which was like, I mean, this is very vulnerable for me right now. Like, I feel like I'm gonna cry because it was traumatic for me. Like, I, am doing my best and trying to provide the evidence and trying to explain everything and trying to understand where that patient is at. And they're like, well, no, like, I just want this, and you're not giving it to me, so I'm gonna leave. And I'm like, okay. And then they, go and write a bad review, right? So, I mean, that was a couple of years ago, and I feel like I'm better and I've improved my skills at assessing those things and making sure. But I've heard this story hundreds of times. It's not just me. And I know that from my research and talking to other people. it might not be as dramatic as that was, but I've heard so many clinicians say this, that though that patient never came back, or, I tried so hard, and they all left, and and then I just started, the first thing that I did with every patient was put them on the table and started doing just like massaging them, and then I got them all back. And I was like, what? That's insane. And they're like, what am I supposed to do? And then what they would do is, once they got that patient trusting them, then they would change the narrative and say, okay, now that, we've done all this, and you trust me, and I know all about your family and your kids and this and that. And, you have all this rapport developed, then you're at a starting point of trust that you can say, well, how about this? And how about this behavior change? And how about we do this and that? And it actually tends to work better. Which is the exact opposite of what the evidence says, which is start with education, and don't put your hands on people. And it's funny because I was a huge proponent of telehealth, and I was like, telehealth is the best thing ever because it forces us to not, there's no opportunity to use our hands. We have to talk to our patients. We have to do all this stuff. And, but then it didn't, there's no patient demand for it. Here in British Columbia, we all weren't allowed to practice for a couple months during COVID in 2020. So we all went on telehealth, and we had tons of patients on telehealth. And then as soon as the clinics reopened, that it was whoop, whoop, it went up and then it went down. Then there was no demand for it because, yeah, I mean, it's multifactorial, but yeah, I'm going on a tangent, but it's so complex, right?
Mm-hmm. What are the downsides of using our hands?
Yeah, I mean, your other question was, what's the risk of not following the guidelines? I think it was something along the lines of that. And what's the risk of using our hands? Well, I mean, there's that psychological risk, I think, is the main one. So there's the risk of developing reliance, and there's a risk of, I guess, there's a risk at taking longer to get to the end goal. But I guess the argument is that if you can never get to the end goal because you're not using the right tools that the patient responds to, then I guess you're failing anyways. And so yeah, it's tricky.
Yeah, I initially a few years ago thought that there was an increased reliance on providers if hands-on treatment was utilized, but it seems has that really been studied that creates dependence, or is that just a potential thought as to what it might do?
Oh yeah, I can't give you a list of references on that right now. So you're probably spot on that. I mean, the problem with a lot of this is it's really hard to study, right?
Mm-hmm.
I mean, I struggle with that as well. It's you can do a lot of qualitative work. You can ask people and talk to people, but that's not causality as well, right? It's important to understand that just because somebody says something doesn't mean that it's necessarily going to play out, right? And so sometimes it's quite hard to look at those trends, especially in the context that we're talking about, which is private practice, orthopedics specifically. So it can be challenging. I think there is a lot of value in using your hands as well. In one of my research studies, I look at the meaning of pain and during physiotherapy treatment and assessment. And I mean, you've probably heard this a million times, but the patient just they feel so validated when you touch their pain. And pain is this invisible thing that people live with, and especially if it's chronic, right? It's not like a swollen, bruised ankle sprain that just happened. If we're seeing a lot of chronic pain patients, one in 4, 1 in 5, and they just, you just feel so validated if you can elicit any type of pain Now, of course, as a clinician, we understand that just because you touch a trigger point doesn't mean that that's like the cause of all their pain and everything. But it's so interesting, and it really comes down to the lay understanding of our bodies and of medicine and of what healthcare providers do versus the clinician understanding. And that is the tension that we're dealing with here, is that we have an expert understanding, we are informed by the research and the literature, but the patient does not. They have their own views that they develop from talking to their friends and family, from exposure to other therapists, from the internet, from social media, and those views can be very, very deeply entrenched and very difficult to change. And we've seen that with like vaccine hesitancy and everything that's going on in our world. It's just people have these views that are not based on explicit or scientific knowledge. And how do you work within those views and potentially change them if you need to is the messy reality, right?
How do you, and it's so dependent on the context, but how do you decide what views are worth potentially changing over time?
Yeah. I think I said this to you earlier. I was like, I'm not going to have all the answers. The point of the article and the point of my research is to bring this discussion out into the world, right? So, I mean, I really do think that the starting point is just assessing those views, because a lot of clinicians don't do that. I I mean, I remember when I first started and it was like, okay, let's do like a 5-minute subjective. Like, let's just get this done so we can like start the objective. And now my subjective history, it's long. Like especially if a chronic pain patient comes in or somebody that, has seen multiple providers or has a complex, it's like, it's going to take a long time, because I really need to tease out what's going on, not just from like a biological kind of like physiological perspective, but from those other buckets as well. Like, what's going on in your life right now? Like, and of course, like, that's not the question you ask, but you need to assess their views. You need to assess, have you been to physio before? What did that look like? What did you like? What did you not like? What do you like? I literally ask people, what are your expectations of coming here today? And so you start to develop this kind of image of the person, and then you can kind of go from there. I wouldn't say you should ever really start to try and change those beliefs the first visit right away. I think that's where you head for potentially a bad review or something. You really need to understand where that person is at, and then again, you kind of just sprinkle it in without overwhelming them or feeling like they are being attacked, right? I mean, if you try and get into an argument about something with someone, it's just like, think about politics, right? I mean, people have very strong beliefs, and people have very strong beliefs about their body as well. And if you say something, they're like, well, no, that's not my experience, right? You have to be very careful.
Yeah, I would agree. There's a lot of times where my first interaction with them, they're saying some things that are pretty wild.
Yeah, pretty wild.
It's just, is it worth it for me to even bring this up or to try to have this conversation? No, it's like these first few visits and weeks are for us to feel comfortable with each other and that individual to feel safe and
totally
to like actually potentially look forward to these interactions, as opposed to like day one, I'm going to try to trash their belief about
whatever
carnivore diet or trigger points or whatever it is. So yeah, and it's so hard to decide like when to pick and choose some of these conversations and battles, not even battle, but some of these really deeply held beliefs. So,
but the other thing, Chris, I think it's important to say is that that's how they make sense of what's going on. And they just don't have the language or the terminology or the understanding to say otherwise. Like, we always like what's the classic thing? Oh, my hip is out, my rib is out, it's out of place, like all these things, right? Like that's how they make sense of the situation. And so if we go in and be like, no, like it's not dislocated, that's impossible. Like, I think it actually, I don't know if this is a word, devalidates them, or it's the opposite of validation. And they come in there like wanting validation and wanting this kind of like empathy and oh yes, I understand that you're like, this is how you feel kind of thing.
Yeah, that reminded me of, I had a eval yesterday with an individual. She's a firefighter. She had kind of an acute event on the job and thought she had a rotator cuff tear. So she went to go see an ortho. They did cervical and shoulder imaging on MRI, and was completely clean, unremarkable findings. So her explanation, or she kind of went down this path of, oh, I have these really tight lats and I need trigger point. And it's like, there has to be something for them to, it potentially has to be a simple answer. Like, if it's not a structural thing, and if I can't find this rotator cuff tear, it has to be something else that I can identify. And she wanted dry needling, or she wanted some type of like trigger point release. And so it was this kind of moving goalposts of like what they're trying to identify, but it's not up to me to say that that's potentially wrong. I'm potentially providing some gray of like, this is a sensitive area. Fortunately, there doesn't seem to be anything structurally concerning at this point. And even if there was, we would potentially still do kind of XYZ. And it's more like reassurance that we're moving in the right direction, but still kind of like identifying the, like you said, the messiness and the gray of pain, and like moving forward with care. But also, I'm not like, I mean, we're in a clinic where a lot of our chiropractors may provide some of those services. So I have a very easy cop out of saying, you're more than welcome if you want to go to the front and like schedule out with one of our massage therapists or our chiropractors. And I don't, that kind of like pushes the obligation to them that those individuals do those things. And then I go more towards the like conversation, education, and like structured exercise and like gradual exposure to things. So it's a little bit of an easier situation, but it is, to what you said, there is this like, it's them trying to explain what's going on in their body, and who am I to say that like I should invalidate them day one on their beliefs.
Yeah. Well, and I mean, it's just like part of being human. We tend to want explanations for things. We don't like to be kind of in this uncomfortable, vague, like, oh, well, we don't know. That's not very reassuring. And so I find that it's almost like you have to say something to the patient. It doesn't need to be like a specific diagnosis, which is why I like these new terminologies, like rotator cuff related disorder. Like, I don't know, or it just kind of broadens things a bit. Or you might just say, well, I mean, I say it a lot sometimes, like, it's just irritated, or just something like that. I don't know. I don't know if it's the best, but it might be the best that I can work with in that one situation, just to give them something to latch
Totally.
onto.
I've noticed that a lot, like with shoulder or with hip. Like, if someone even has like a diagnosis or a finding of a labral tear, like a hip labral tear, and I'll just say, that may or may not have been there prior to this event.
Mm-hmm.
You just have kind of a cranky hip and it feels pinchy in certain situations. And it's like, you're validating the fact that it's uncomfortable, but we don't have to like be so structural with our explanation, because one, we don't potentially know, and two, they become potentially like anchored to this thing that's structurally wrong with them in their body.
Yeah. And it's so interesting, like, that you mentioned that you're that patient that, went straight through that kind of imaging process, because in Canada, like, it would take like 6-7 months for them to get that scan. And so it's so funny, because I often, like, we're primary care providers. So, a patient comes in off the street, they have, a sore shoulder or whatever. And I'm always like, well, and they ask about imaging. Oh, like, when you get MRI, I'm like, well, like, no, I mean, like, yeah, you can get in the lineup, but honestly, by the time that you get the scan, you're going to be better. Like, and it doesn't change really much of what we do here, you know? So it's just kind of a different system in the sense that, you know, and we're trying to decrease imaging as well. Cause like in a public healthcare system, you know, every time somebody gets an image for something that they don't necessarily need it for, it costs the taxpayer money, right? So it's a different kind of system, but I would say that our scan numbers are still going up because people are still demanding them like crazy, right? So that's a whole nother conversation. I'm sorry. But it's related, right? Like I'm saying, like we're not in a vacuum. There's just so much complexity. And that was actually what I talked about on the last podcast I was on. It's just that there's complexity, increasing complexity around us and increasing complexity of our patients. And you know, with this kind of chronic pain, thing that's going on there's so much more complexity and people are like, oh, I need a counseling degree to be a physio now. Like it's a lot.
So let's go to kind of the second portion of your article, addressing evidence-based practice uptake with a multi-level and multi-stakeholder approach. There's kind of three, it seems like, areas that you discussed: the individual and the PT level, the clinical level, and then kind of within that marketing and client communication, and then the community level professional organizations. So Sarah, can we start out with the individual level of, are there any ideas of how do we increase this uptake and utilization of EBP?
Yeah, definitely. So I think we talk about like selling this as a concept to people. And, you know, in the end, the patient just wants to get better, right? And so, you know, making sure that you're able to tie everything that you do towards that end goal of getting better and them understanding that there's short-term and long-term goals, right? And I think that that's one of the mistakes I made as a newer clinician is, you know, there are some patients that come in that just want that kind of immediate pain relief. And even though it's not providing them long-term solution, you need to meet them where they're at and understand what their goals. Like, you know, if somebody doesn't want to quit smoking, they're not going to quit smoking, right? Like you have to understand where that person is at, what their goals are, and what their beliefs are. And I think that's like the number one skill is listening and then being able to ask the right questions. Really, I mean, it's being a researcher has made me a way better clinician because I'm so interested and I'm so much better at asking the right questions. And as a new grad, if you're not getting that training in how to ask the right questions, like motivational interviewing type training, you're that's probably the number one course that you should do right away. It's not you know, another manual therapy course. It's like that's what's going to get you success on this evidence-based practice journey, and also really going to help you create like lasting change and make your patients like be better humans and healthier and everything. So I think it's really looking at the clinician's skill set. I don't think that people change overnight and I think it's important to realize that. So some general principles is ask lots of questions, ask the right questions, get the training to be able to understand what those questions are, and make sure you assess where your patient's at.
Maybe this is a whole nother podcast, but asking the right questions, is that more so the skills that can be utilized in some type of motivational interviewing or reflective type of conversation? Or do you have any examples of like asking right or better questions, what that actually looks like?
Yeah, I mean, it's going to vary. I think it's like more the depth of the question, right? Because you can ask somebody like, how's your overall health? And they're going to say, good. But then if you start asking them, like, have you been diagnosed with cancer? Have you had a heart attack or stroke? Like, have you ever had a surgery before? They'll be like, I had cancer last year. And you're like, what? Like, and I mean, of course, you're supposed to be asking those questions because they're contraindications for certain things that we do. But I mean, that's a great example of you need to get to the depth of what's going on. You could ask about their physical activity as well. It's like, well, what do you do for physical activity? Oh, well, I run. Well, how often, how much, and oh, well, I actually don't run right now. I used to run like 3 years ago or whatever. And it's like, and then it's like, if they don't do anything right now in terms of physical activity, well, what did you used to do? Or did you play sports as a kid? Like, you're just trying to really develop the picture of that person. And that kind of line of questioning can apply to anything in the subjective history. It's like, there's like these kind of umbrella questions you can ask, and then there's these kind of deeper level questions. And then of course, when it comes to the motivational interviewing and things like that, then it comes more towards behavior change, right? So it's like, have you thought about this, or why didn't, or what's your motivation for that, or why haven't you done that, or what was your experience like when you did that, or like trying to kind of get to the crux of what's preventing them from moving forward with a certain behavior, right?
Now, at the clinic level, what does this look like, and what are some examples or things that could potentially increase uptake on the clinic level?
Yeah, so I think that's about creating the structure, right? I mean, we always talk about it's so much harder for individual people to make behavior change. It's so much easier for the structure to change, and then the person they don't have to do anything, right? Like blood donation. If you make blood donation organ donation. If you make organ donation mandatory, then there's going to be way more people donating organs, right? It's like opt in versus opt out. Because people just don't opt out, right? So that's like a very easy way to make change happen. So if you change the structure that clinicians are operating in, it's less of an issue. We see that in public versus private practice. In public practice, you don't have the same, like you have your secured income, you don't have as much competitive pressure, so you can give care in a different way. You might have longer time, and you don't have to worry about the same pressures that the clinicians face in private practice. Of course, those do not translate directly to private practice. So one way could be to have more of an employee model, have longer patient visits, which is obviously quite tricky because then you have to charge patients more per visit. But also having like alignment of incentive structures, right? So right now, the incentive structures are not aligned. They're more aligned towards just doing whatever the patient wants. But if the incentive structures are aligned towards evidence-based care, then it'll be a lot easier because you just won't get paid if you don't do it, right? So, defunding things that don't follow the evidence could be another way. I don't know, like every country has different structures, and I think it's different in every state and things like that. So if those things weren't funded, people would think twice about them potentially. And then also creating the structure, like the mentoring structure in the clinic to support those types of interventions, and holding in services and practicing those type of skills, and making sure that new clinicians are supported with those skills. Another easy thing to utilize is an intake form. Assessing some of those beliefs that the patient completes on their own could actually also save time as well. Those are just some of them. I mean, there's this. I don't have all the answers. There's so many more, right? What are your thoughts, Chris? What do you do in your clinic to help with this?
Yeah, fortunately, I think a lot of this is on the clinician level or individual level. If a patient has a good experience, a lot of our referrals or a lot of our new patients come from word of mouth. And so it is, the marketing comes from the patients that we discharged and them discussing how it went and what it looked like. And also just the structure of our clinic sets the expectation for what care looks like. It's a very open clinic format. It almost looks like a gym. All
Right.
the providers are out on the floor. Like, it immediately sets the expectation that this is going to be an active process for the majority of the care. And the marketing can be directed towards that. But we're also in a big multidisciplinary clinic where we have sports chiropractors, we have physical therapists, we have the orthopedic department, we have athletic trainers, we have massage. So there are potentially some different kind of viewpoints and treatment views, but at least the expectation you come in with is this is a big sports medicine clinic where active care is the majority or the primary thing that's going to occur. But I'm not directly involved with any of the marketing or any of the, like, how the clinic spreads to the community, besides my own patient-to-patient interactions and hopefully providing a good enough experience and good enough outcome to the amount that I have control over that process, that the patients leave and go to the community, and that spreads and others come back. So yeah, that's my experience with it.
That even speaks to like clinic culture, right? It's like your branding. It's what patients have come to expect, right? I go to this clinic for this type of experience, right? And as you said, that's part of the layout of the clinic, right? If you walk into a clinic and you don't see anybody exercising, you don't see any gym, you don't see any of that, it's going to be a very different expectation, right? So, we have to brainstorm solutions for people who, here, like, rent is so high for spaces. So in order to have a big space, it can be like, it's just, you can't even run a clinic. You're in the negative. But, there might be ways to still have that branding. And I think one of the ones was the images that you portray and the types of advertisements that you put out and the types of kind of social media posts and the terminology that you use. I think that all plays into when I come to this clinic or this brand, or when I'm interacting with this company, I'm going to have this type of experience, right? So setting those kind of standards there. And so I think we do ourselves a disservice when all we do is show ads of, people lying on treatment tables. There's so much more that we do, of course.
What about the big community and professional organization level? What does that look like?
Yeah, I spoke in the article about starting off kind of with the education system and looking at curriculum reform and kind of trying to focus more on those soft skills and building that out and practicing that, because I didn't get any of that in my education, and I don't think a lot has changed because I'm pretty well informed on that front with new grads and everything. But the other thing is the role of our professional associations as well, because they, build awareness for our profession and educate the public. And so there's a big role for that type of support to happen, and building kind of communities of practice around evidence-based. And most people, when they think about evidence-based, they think about, doing a study club or reading articles. And I think it's so much more than that if we want to change the way that our profession is viewed in the public's eye. And, we can't, if we want to be seen as therapeutic exercise, specialists and really highlighting that scope of practice, then a lot of our messaging needs to change. And we need to, the associations are a way to unite the disparate clinics, right? And do you guys have associations as well, state level? Or
Yeah, we have state, and then the APTA, the American Physical Therapy Association.
Right. Yeah. I mean, I just think that there's a role there for connecting the messaging. Like, can we come up with a kind of central messaging that we're all going to agree on? I mean, it's easier said than done, but I think that even like as a new grad, I really struggled to describe to patients what we do. And I think I ended up saying, well, we're kind of like chiropractors and massage therapists and acupuncturists and kinesiologists. We're kind of just like, we're a bit of everything. And like, that doesn't give us our own identity, right? And I think that people should be coming out of school being like, this is what we do. And I'm confident in that. And, you know, I think that can be very challenging because physio is in so many different realms. We just had our strategic planning session for my professional association, and one of my things was like, I want us to be the doctors of MSK, and then it's like, oh no, but it's not just MSK, it's cardio resp, it's neuro, it's all these other things that we do, right? So our scope is so broad, it becomes difficult. And maybe I'm giving more questions than answers, but I mean, that's the point. That's the point of the article, right? Is to get that conversation out there and talk about all these things that make it challenging to put evidence into practice.
Do you have a better idea of explaining to a patient or to lay public what it is that you do now?
I do. I'm saying it's still a work in progress. But you know, I often say that we're movement professionals and we're interested in helping you achieve your health and well-being goals, and that you often walk in the door of physiotherapy with an injury, but that doesn't mean, but it's often actually an opportunity to address many different components of your well-being. And again, so that's quite long-winded, but in trying to encompass that we are partners in health and facilitators for people to achieve the sport, health, and well-being goals that they want to achieve. Do you have one, Chris? What do you say?
No, that was way better than I would have ever done. I haven't thought about it, and I'm glad I haven't been asked because it is so messy. And then trying to give an answer for that as PT as a whole, like you said, there's so many different areas: neuro, acute,
Exactly.
peds. So it's tough with a education, to your point of this is a lot of this isn't taught in schools, but if it's a 2-year master's or 3-year doctorate, there's already so much information and we're already just skimming the surface on the majority of things. How do we even get more information that's necessary in such a tight window of graduate level education, and you're just like trying to stay afloat as a student, and then you come out and realize all of these factors that you talked about. It's really, really tough, and then it feels overwhelming. And I'm glad you separate it from this kind of like individual level, the clinician or the clinic, and then the community, state, national organization level. And all of those need to be addressed, but it can feel heavy to do that as one person. So how do we as a unit move in a better direction?
United. We need to unite, not argue.
Are you optimistic about the future of physio, at least in Canada or in your local community? Or does it feel like you're becoming more and more pessimistic or frustrated?
Oh man, I feel like it's so easy to be pessimistic about everything now, right? But I honestly think that physiotherapy is going to fix the healthcare system. Like we just have so much potential. And that was actually my personal mission statement in the strat planning, was to unlock the potential of physiotherapy to solve the problems that our society is facing today. And we just have so much to offer. And I would like there to be much more visibility of our profession. I think it is greatly improved, right? Like, you know, my grandma doesn't even know what a physiotherapist is, right? But, you know, the newer generation are coming to physios first. And we just we are this interesting middle profession where we can just assist and have so much more time with our patients than doctors, for example. And we just have so much potential, really. It's amazing. Like, all physios, I feel like, have these amazing skill sets. And you see someone like yourself, Chris, you're doing a podcast. Like, you're not just in the clinic, right? Same with myself. I mean, most physios, they always doing all sorts of different stuff, and I think that really speaks to the type of person that is a physio, and just the types of passions that we have to make the world a better place. I think there's a lot that we can do. So I'm despite the article, which might seem like it is pessimistic, I'm actually optimistic.
Well, I'm glad you're optimistic, and I'm appreciative of you putting out this information and being in all the different areas that you're in currently. Is there anything you feel like we didn't touch on that you want to chat about before we wrap it up, or any summary final thoughts?
Uh, Chris, I think I would just say, like, that we need to have empathy for each other as clinicians, and try to be less judgmental. It's very easy to jump to conclusions and to argue with someone without understanding those deeper level questions about what's going on. And so we should, just like we have empathy for our patients, and we don't go and say, well, you're completely wrong. That's not going to get you very far with your patients. I think we need to have open and respectful and empathetic conversation with other physiotherapists. And, we all came to this profession, hopefully almost every single one of us, because we've been touched by this profession in some other way, shape, or form. And we really care about our patients. And we're all doing our best. We're trying in the circumstances that we're in to be better people and better clinicians. And I really think that we need to unite as a profession and move it forward so we can solve societal problems.
I think that's a great place to stop. Thank you so much, Sarah. This was great.
Yeah, thanks.